Good evening everyone, it's 27th of July 2025. Good evening everyone, it's 28th of July 27th. Good evening everyone, it's 27th of July 2025, Sunday, 8:10 p.m. here. So in this video I'm going to read about botulism from Vienna. It's not very important for ophthalmologists, like it's not must thing to know by an ophthalmologist because these cases are handled by medical residents. So yeah, MD doctors, medicine specialists, people. So botulism introduction. Botulism is a potential life-threatening disorder caused by the toxin of Clostridium botulinum. Three types exist: foodborne, wound, and infantile. The clinical picture is characterized by rapidly evolving cranial nerve and respiratory weakness with autoimmune dysfunction. Associated symptoms include hyposalivation, dysphagia, dysarthria, respiratory failure, muscular weakness, constipation, urinary retention, nausea, and vomiting. Epidemiology and pathogenesis. Botulism caused by the neurotoxin elaborated by Clostridium botulinum may take many forms. Its site of action is the presynaptic nerve terminal, where it prevents the release of acetylcholine. The preformed toxin may be ingested as in foodborne botulism or gain access by wound infection. Alternatively, the bacterium or spore may colonize the gastrointestinal tract as in infant botulism. Inhaled botulism via aerosolization of the toxin is a potential bioterrorism weapon. At least 8 types of toxins have been described, but only 3 forms commonly affect humans. Type A botulism is usually the most severe form of the disease. In the United States, an estimated 145 cases of botulism are reported yearly. 50% of them are foodborne, 75% infant botulism, and 20% through wound infection. Historically, classic or foodborne botulism was caused by inadequately cleaned, smoked, salted, or dried fish or meat. Contemporary risk factors include commercial or home-prepared condiments, vegetables, non-acid foods, and preserved raw fish. Plastic food storage bags and containers provide a near-perfect anaerobic environment for growth of Clostridium botulinum. Vehicles for foodborne botulism vary by region worldwide. Infant botulism occur during the age range 2 to 6 months in previously healthy infants. The course is subacute and may be difficult to diagnose until the child becomes severely ill. The classic source of infection is honey. Transmission of spores from adults to infants is possible from soil contamination of clothing. A similar infection can be seen in adults who have achlorhydria following gastrointestinal operations and who have blind loops of the bowel. Wound botulism was once an uncommon form of botulism but is increasing in incidence as a result of intravenous heroin abuse and cocaine abuse associated with necrotic nasal passages. Ocular manifestations. Ophthalmic manifestations are not likely to occur in isolation but are part of a systemic illness. Diplopia and ptosis occur with varying degrees of ophthalmoparesis. Internal ophthalmoplegia with accommodation paralysis produces blurred vision. The pupils often are abnormal with a poor reaction to light. Pupillary light near dissociation may be observed during the acute infection and occasionally persists after recovery. Quivering eye movements have been described. Hypolacrimation is often found. Diagnosis. The diagnosis is based on the symptoms and signs, the circumstances of infection, electrophysiological studies, and isolation of the organism or toxin. When botulism is suspected, stool, gastric aspirate or vomitus and at least 20 ml of serum should be collected for analysis. If the source of contaminated food is available, it may be submitted to the relevant health department for evaluation. Identification of botulinum toxin in serum and stool is performed using a mouse bioassay. A tensilum test result is almost always negative. Electrophysiological studies are very helpful and show changes similar to those seen in the Lambert-Eaton syndrome. Lambert-Eaton syndrome is what? Antibodies against the presynaptic voltage-gated calcium channels, which again in turn result in the same, that is decrease in the acetylcholine release. Differential diagnosis. The Guillain-Barré syndrome, Miller-Fisher syndrome and poliomyelitis resemble botulism clinically. Myasthenia gravis spares the pupils and is more gradual in onset. Tick paralysis, diphtheria, organophosphate toxicity, shellfish toxicity, ischemic locked-in syndrome and hypokalemic periodic paralysis are other diagnostic considerations. Systemic associations. Symptoms of foodborne botulism begins 12 hours to 8 days after ingestion of the toxin. Typically, the patient is conscious and febrile. The characteristic systemic symptoms include hyposalivation and respiratory failure, urinary retention, constipation, and vomiting. Limb weakness may resemble that of Guillain-Barré syndrome with ascending or descending paralysis. The reflexes are often normal or hypoactive. Prominent bulbar symptoms and cranial nerve palsies may develop. At worst, the patient is locked in, unable to move or respond, but fully awake. In wound botulism, symptoms begin 4 to 18 days after the injury and are identical to those of foodborne botulism. Infant botulism causes constipation and weakness with descending paralysis. The infant has a poor suck and a weak cry and becomes hypotonic. Impairment of extraocular movements, facial weakness and cranial nerve palsies are common. Dilated pupils, respiratory arrest and death may follow. The course often is insidious and mistaken for Felix child. Treatment. The most important aspect of treatment is supportive with mechanical ventilation when necessary. If the patient is not allergic to horse serum, pre-testing for hypersensitivity is required. Heptavalent botulinum antitoxin is administered in a single treatment. Human-derived botulinum immunoglobulin, baby BIGIV, is effective for treating infant intestinal botulism. Recovery occurs spontaneously as new synapses develop. This may take 6 to 12 months.